Thank you so much. And I'm really looking forward to speaking to you about the Lancet Commission on Ending Stigma and Discrimination in Mental Health. So I'll share my presentation. To get the word out to both media houses globally, but also locally within countries. There are two very important messages that we wanted to bring across. And one of these were stigma powerfully and adversely affects individuals, communities, families, and society, and it is persistent and it exists across cultures. So such forms of social exclusion are quite simply no longer acceptable. Hence the ambitious call for ending stigma and discrimination. Another key message is that it's time to end forms of stigma and discrimination against people with mental health conditions, for whom there's a double jeopardy. As we know, the impact of the primary condition itself, and then the severe consequences of stigma. So I had the pleasure of working with an excellent global team of experts. I co-chaired this commission with Professor Sir Graham Thornycroft from King's College London, who's quite an expert in the field of stigma. I think it's important to mention first that this report was co-produced by people with lived experience. And of course, that includes myself having a lived experience as co-chair, but also across the commissioners and advisors. We had 22 commissioners, most of whom were from low and middle income countries. And then also on our advisory board, we had a total of 22 members. So all our contributors came from 26 countries worldwide. Another way of how people with lived experience were also involved in this report is through many poems that we received on the topic of stigma and discrimination, where they were able to express in the literary arts form of how stigma and discrimination impact on their lives. I think we received over 100 poems from people really across the world. And in the report itself, we selected 6 of those poems. It went through a selection process. We also included quotations from people with lived experience. Most of those were from the lived experience survey that we conducted, which I'll speak about in a moment. And that was also used throughout the report, but also in supplementary items. I'm now going to play one of the poems that is read by Camilla Fitzjohn, and her poem title is My Own Private Nightmare.
My Own Private Nightmare by Camilla Fitzjohn. Hard to believe it. Where am I? What have I suddenly become? I've plummeted. Can I sink any lower? Labelled mentally ill, put and contained, a mental straitjacket. I can barely stand up. I cannot read. My eyesight is blurred. The nurses are kind, but I have an inner sadness, longing for the outside. I decide, if I leave now, this won't count. It will be just a nightmare. Leave now and you will be sectioned. I stay. Medication makes me fat, slow and dull-witted, labelled self-indulgent by my professor, nerve endings tingling with humiliation, feel alone and cold, stuck on a private island nobody wants to visit. Backs are turned, hostile stares, no one sees the real me. What's under this cloak of insanity? Getting used to being ignored, settling for being misunderstood. Hooray, how I cheer for this new, brave, thoughtful generation. Thank you for supporting and tolerating minorities, liberating us, cancelling prejudice. Thank you, New World. My own pride.
Yes, so that was one of the poems. There are several, and all of those that we received were extremely powerful. But just to look now at the aims of the Commission, we aimed at defining stigma and discrimination, to really look at the levels in which stigma occur. We aimed at summarizing the impacts of stigma and discrimination, how it impacts on people's lives at different levels, what barriers are created, how behavior are towards people with mental health conditions. And then we also wanted to conduct a review of the effectiveness of anti-stigma interventions. We also aimed at assessing the experiences of large-scale anti-stigma programs. Within those programs, we also aimed at interviewing people with lived experiences specifically around their involvement in such programs. We wanted to understand specifically the roles of the media, and finally to set key recommendations that are actionable to call to end stigma and discrimination in mental health. So I previously spoke about the global survey or with people with lived experience. So we wanted to obtain people's perspectives, but also what their priorities are in terms of stigma and discrimination. This survey went out globally. We received 391 respondents from across 45 countries and territories. Of course, we would have liked to receive a lot more representation across countries, but I suppose there were various potential challenges in terms of that. For example, language barriers, also people not being able to access the internet because this survey was done online. But what we did to really try and reach a lot of people was we translated the survey and made it available in the 6 official languages of WHO, which was English, Spanish, French, Arabic, Chinese, and Russian. So 65% of the respondents came from upper middle income countries and territories. And just to break that down, 5% of those came from Africa, 13% from America, and probably the largest portion with 47% from the European country. We actually, within Europe, we received a large number of respondents to the Spanish survey. So hence that large number for the Europe region. 2% were from Eastern Mediterranean, and 3% Southeast Asia, and also quite a big portion, with 30% from Western Pacific. With that number was due to a large responses specifically in Chinese. So in the survey, we had qualitative and quantitative questions. From the quantitative questions, we had several statements and asked people to either agree or disagree. And just from those statements, it was quite interesting to see how many responded positively to these statements. So 93% agreed that people with lived experience should be treated as well as people with physical health conditions. 9% agreed that stigma and discrimination negatively affects most people with a mental health condition. 90% agreed that the media can play a major role in reducing stigma and discrimination. 83% noted that government should invest in long-term national programs to reduce stigma and discrimination. And 80% agreed that stigma and discrimination can be worse than the impact of a mental health condition itself. And then 71% agreed that the media is a major factor in making stigma and discrimination worse. So that is also why we had quite a big focus in terms of the media's role in stigma and discrimination. Just some interesting things that we also included in the report. We had a look at, where stigma originated from. We had a section on that. And it's interesting that the word stigma comes from ancient Greek, where it's referred to as a tattoo. So it was used to visibly mark slaves and all criminals as members of society with diminished value. So later in the 20th century, it was defined as deeply discrediting. So it reduced a person from a whole and usual person to a tainted and discounted one. So this is why we really, really need to start going into stigma and really end it, because it has such a negative impact on people's lives and also their communities. We did look at the types of stigma. So we went into that. We categorized it into these. Self-stigma, which was also, of course, known as internalized stigma. Stigma by association, which is also known as affiliate or courtesy stigma. And then public stigma, sorry, which is probably the more commonly known, which is subtypes that is based on like misinformation, based on people's knowledge around mental health and mental health conditions, prejudice, which is based on people's attitudes, and then discrimination, which is how people react and their behavior. Then we have structural discrimination, which is also known as systemic stigma and organizational stigma. And with this category of stigma, there's actually not a lot of research done around this specifically. So just to look at what each of these actually mean, just to use some examples. Self-stigma is when someone kind of look at themselves negatively because of how they see other people react to other people with a mental health condition. So they would, for example, say, because I have a mental health condition, I must be incompetent. Stigma by association. Families, relatives of loved ones with a mental health condition are also stigmatized themselves. For example, when families are blamed for the onset of substance use condition. Public stigma, I mentioned the subtypes. So people often perceive, especially people with schizophrenia, for example, as dangerous, and overall seeing people as being incompetent, and that mental health conditions cannot be treated. And that, of course, generates a reaction where people avoid people with mental health conditions. So they maintain that social distance. Paternalism is also another thing that happens in terms of the reaction, because someone would believe that someone is competent when they have a mental health condition. So they would make decisions for the person and believe they're doing it in the best interest of that person. So paternalism also often leads to coercive practices. So because of public stigma, the reaction can also be support for coercive policies and practices. And then structural stigma, that's also often ingrained within systems. For example, property rights, where someone with a mental health condition or not cannot own property. There's also voting rights that's affected. I know in South Africa, our electoral act did, I'm not sure if it changed it, but I've been involved in trying to change that specifically. It did refer to people with a mental health condition not being allowed to vote. And then in some countries, there's even provisions around marital issues. So someone not be allowed to get married or have a family when they have a mental health condition. So the impact of stigma. In the report, we summarize the impact on 4 domains. First of all, the personal impact, and that includes self-stigma, quality of life, how stigma affects a person's quality of life, and of course, service use. We do know that stigma is quite a big factor where people are too scared to go and seek help because they're afraid of how people would respond when they know they're seeking help for a mental health condition. And then structural impact was another domain, and that, of course, as I mentioned, include legal provisions, also human rights, and the implementation of psychosocial interventions. Another domain was the impact on health and the social care sector, and then social and economic impacts, which includes employment and work. The report also looked into terminology, and that was also some of the questions in the lived experience survey, asking people about how terminology affect them and whether it has an impact on them. And one of the quotes specifically said that language is used to broadcast shame, making what was a private individual experience a stereotype experience. So we do know that language is an important and powerful vehicle because it shapes attitudes, it contains values, emotions, and perceptions, and it guides how people react. So what people with lived experience recommended was that we use kind and non-derogatory terms. Here is some of the words that were identified by the lived experience participants as derogatory terms. I think most of you probably know many of these terms from schizo, insane, psycho, crazy, mad, deranged, schizophrenic, mental patient. Maybe just to say, I personally do not prefer the term mental patient or patient because I am only a patient when I'm in a hospital. Outside, yeah, I'm just a person. So the participants also felt very strongly about that words do matter when it comes to how people are referred to, because it reflect and reinforce negative attitudes and behaviors when we use derogatory terms. And it can cause really serious harm to the individual who's affected by a mental health condition. The key principles that we must always bear in mind when we refer to someone with a mental health condition is that we need to address the individual as the person and not as their condition, because we are not defined by our mental health condition. We just live with it. But even in the survey itself and also engaging with a lot of people with lived experience, it's very difficult to come to a common preferred term or common preferred terms on how individuals would like to be addressed. But it's always recommended to ask the person how they would like to be referred to. In the peer network, for example, we refer to lived experience, mental health condition, also sometimes psychosocial disability. But that is how we prefer. Other people sometimes do not like to be preferred as lived experience or having a mental health condition. But the key aspect is that we always need to avoid derogatory phrases. So how we address a person is on a person-first approach. So it's a person with a lived experience of a mental health condition, or person with a mental health condition, or person with a psychosocial disability. The term psychosocial disability is actually strangely quite often used in Africa. It's also more often used in terms of human rights instruments. A lot of human rights instruments reference psychosocial disability in the broader disability phrase. So anti-stigma interventions, we reviewed a total of 216 systematic reviews. And what came from that, it showed that interventions that are based on the principle of social contact, and that I'm not sure if everybody's familiar with social contact, that also can be contact-based education. So it's like a person with me, like engaging with other people, non-lived experience people, either sharing my story or just speaking, or someone in the community, someone working with a person with a mental health condition, just that kind of contact. That can also be virtual and in person or indirect. So that has shown that it have been, when it have been appropriately adapted to different contexts and cultures, that it's most effective way to reduce stigma worldwide. With a virtual and in person, the important aspect that came from the reviews was not in terms of, whether it's in person or virtual. What came out, the most important is the quality of that social contact. We often get people who train people how to share their recovery stories. And that is very important because they get trained on how most effectively share their recovery stories. So it's the quality of that content. So these are the large-scale anti-stigma programs that we assessed. So you can see across from high income right through to Australia. Here on the right hand, this panel is in the report itself, so it just speaks to what each of these anti-stigma programs focus on. They do focus on different things. For example, the Carter Center focus a lot on journalism. I know Time to Change Global specifically worked with champions within Kenya. So there's like the training I referred to, they also trained people on how to share their stories. And then the anti-stigma programs, these were the 10 that we evaluated from around the world. What came out, why these programs are most effective, it is when they involve people with lived experience of a mental health condition as co-producers in all aspects of the development. And also when they target groups, the target groups are consulted on the program content and delivery. For example, if the target is on, let's say, medical professionals, it's always important to also include a medical professional into the content and delivery part of the program. Of course, lived experience as well. And it's also most effective when the programs are sustained over long term. For example, we often raise awareness around mental health on World Mental Health Day, so it's once a year. That is not sustainable. Addressing stigma must happen consistently. So the role of the media, here was some interesting aspects in terms of the media. What came out was that the media can play a role in increasing stigma. And that is when they reinforce stereotypes associated with mental health conditions. For example, talking about people as being unpredictable or dangerous. But at the same time, they can also play a powerful role in decreasing stigma. And that is when they align guidelines on responsible reporting. For example, on suicide. Just to mention, there's quite a large kind of campaign around decriminalizing suicide. I think there's about 20 countries that still criminalize suicide. And also in terms of how we refer or speak about suicide, we always say a person committed suicide. The word committed kind of makes that connection to a crime. So it's always advisable to speak about a person rather saying a person died by suicide. So the key findings of the commission, there's some three specific findings that came from the report. I think what we wanted to bring across as well is that mental health is being part of being human. So we have to stop stigma and start inclusion. Inclusion is very important to eliminate stigma. So the one finding was that the consequences of stigma violate basic human rights. For example, people with a mental health condition, the chances are very slim that they would find a job, probably in many countries, once they disclose their mental health condition, especially people with severe mental health conditions like schizophrenia and bipolar mood disorder. But it also limits educational opportunities and access to healthcare, including mental health care. Another finding was that stigma can be reduced through social contact, as I mentioned, between people do and do not have lived experience of a mental health condition. And then what's also very important finding is that people with lived experience of a mental health condition should be empowered and supported to play active roles in stigma reduction efforts. I think we living with mental health conditions know exactly how stigma affects us. And maybe just to mention some experiences I personally had was when people would say that doesn't look like or sound like I have schizophrenia. But it just shows you how people think that you must look or sound in a certain way. So when you have that social contact, people actually see you as human. So it brings that human element into conversation. So we had the principles that guided our recommendations. And this was that all human rights must apply equally to people who do and do not have lived experience, and that provisions for social inclusion of people with disabilities must apply for both physical and mental health conditions, and that health and care provision should be equitable regardless of physical and mental health conditions. And also that no country should have laws that unfairly discriminate against people based on their mental health condition or suicidality, and that initiatives to reduce mental health stigma and discrimination must be co-designed or co-produced with people with lived experience. Probably heard me say this quite a lot of times, but this was really an important thing that came out of this report. So the recommendations, there were 8 key recommendations for action, and they were aimed at different stakeholders, international organizations, example, Psychiatric Association, World Health Organization, UN agencies, and so on, governments, employers, the healthcare and social care sectors, the media, and people with lived experience, but also local communities and civil society. So each of the recommendations had specific target and indicators that we will be using to develop a framework for accountability and track progress towards ending stigma and discrimination in mental health. Here is the recommendations. I'm not going to go into each of these. I just wanted you to see the targets and the indicators specific to each of the recommendations. Recommendations 1 is for UN agencies to be led by WHO, to work with heads of states and health ministers to implement the reform of mental health policies, plans, and laws, to make sure that these are aligned with international and regional human rights instruments. And that also makes specific reference to how it is set out in the WHO Comprehensive Mental Health Action Plan. Recommendation is also directed at WHO and its international partners, and that they are responsible for developing an issue and encourage the use of an evidence-based practical toolkit and adapt that and implement in all countries to reduce stigma and discrimination. Recommendation 3 was aimed at governments, so all member states of the UN to call to take action under Objective 3, specifically again under the WHO Comprehensive Mental Health Action Plan, to amend and repeal legislation that perpetuates stigma, discrimination, and human rights violations against people with mental health conditions, and also specifically the demonization of suicide, and also to contribute to the SDGs around suicide reduction. Recommendation 4 was specifically aimed at employers, and that again, UN member states, agencies, and employer organization to implement guidelines, which was recently launched actually by WHO on mental health and work, and to apply them to Apologies for that. I bombed out for a moment there, so I shall continue from here. I'm not sure if you heard recommendation 4 about employers, about WHO, who recently published their mental health and work guidelines. So just for governments to implement that. And then maybe something that's most of interest to your organization specifically is the target, the aim at health and social care sectors, and that involves training, pre-qualifying courses for healthcare and social care staff that should include evidence-based sessions on stigma reduction among providers and help providers to respond to stigma and discrimination experiences. And that also recommend that people with lived experience must be involved in the training. And then recommendation 6 looked at the media specifically, that all national and international media organizations, traditional and new media, that of course includes social media, should be called upon to issue policy statements and action plans on how to promote mental health and also to contribute to the reduction of mental health and discrimination and stigma in mental health. The last recommendation, number 7 and 8, was aimed at people with lived experience, communities, and civil society. And that recommendation specifically spoke about programs for reduction of mental health-related stigma and discrimination to be led or co-led by people with lived experience. Recommendation 8 spoke about funded programs must be available to support people with lived experience to be involved in anti-stigma programs. And that looked at 3 categories. First one on mutual help and peer support networks. Also integration of people with lived experience as providers of health and social services. For example, peer support workers. I know peer support workers, I'm not talking about peer support groups, but peer support workers as a speciality or kind of an occupation as part of the mental health workforce is referred to here. That has the potential of reducing stigma as well. And of course, then service users to receive support when they do disclose their mental health conditions or make that decision to disclose. Yeah, you'll see in the indicators, there's a lot of reference made to specifically the WHO action plan, because it clearly makes a reference to stigma and discrimination. Just read this. The vision of the action plan is a world in which mental health is valued, promoted, and protected. Mental health conditions are prevented, and persons affected by these conditions are able to exercise the full range of human rights and to access high quality, culturally appropriate health care and social care in a timely way to promote recovery in order to attain the highest possible level of health and participate fully in society and at work, free from stigmatization and discrimination. So yeah, some of the goals, I'm just going to quickly go through here through each of them. That infographic is part of the information on the website of the Lancet. The goals of this commission is to international and non-governmental organizations should issue guidance that all forms of stigma and discrimination towards people with a mental health condition are unacceptable. That governments of all nations should implement policies to support the end of stigma and discrimination, and to ensure that stigma and discrimination against people with lived experience in the workplace is eradicated, and that national training curricula, all healthcare and social care professional and vocational training courses should include mandatory training sessions on the rights and needs of people with lived experience and co-delivered by people with such conditions, as I spoke about, to be included in training. And then all media organizations should systematically remove stigmatizing content from any of their products. And then people with lived experience must be strongly supported to reduce stigma and discrimination. And that is the end. I'm going to leave this slide a bit up here. Here's a QR code to the website where you can access the report and supplementary materials. This will be available free, I think it's 50 days after the launch, so you still have time to download and access the materials. So if you can maybe take a photo of the screenshot. And then just to say thank you very much for listening to me, and I hope I could be able to teach you a bit more about stigma and discrimination. And if you like to contact us, both my co-chair, Professor Graham Thornycroft, here's our email addresses. Thank you very much.
Thank you, Charlene. We do have a few questions in the chat, if you would be able to assist with some of them. We have a question: how can a family of a person living with psychosocial disabilities assist in reducing the stigma?
Okay, yeah, let me answer that one. Yes, I think it's important for families to be educated themselves about mental health conditions. Also about human rights issues, because if they are able to support their relative with a mental health condition, that also improves the relationship, and that also avoids any friction or any self-stigma on the part of the person living with a mental health condition. I know there's another aspect to that when we speak about families. I think families are often very much left out of the treatment of people with mental health conditions. And they are often not supported, and I think, or involved in the treatment. And I think that is important to include that, because that's also a way that we can empower family members as well. I hope that answered the question.
Then we have, under different kinds of stigma, what effect may there be if the person experiences self and structural stigmas?
I think maybe a simple answer would be that when you have self-stigma, you may not recognize when you experience structural stigma. Or you might not know how to deal with that, because you think you are, like I say, useless almost. And I think that also may make self-stigma worse if you also at the same time experience structural stigma.
And we have a question: how do you reduce stigma when individuals are brought up being taught that, for example, real men don't cry? If you cry, you are weak or depressed or you need help. How do you change that adult perception?
Yes, that's a good one. I personally believe that it's important that we start anti-stigma programs at school level. We need to teach kids right from the beginning, that it's not okay to treat people differently. I think we come to the diversity. I always say that we shouldn't be ashamed of being different, and that includes having a mental health condition. We should see it as something to celebrate. And I think if we teach kids right from the beginning that not to see other people as being different, that it's wrong to be different, because ultimately they will go, speak with the parents. But then it's also the parents themselves who also need to use the correct terminology. I know we often say, this person is really crazy, or no. Let's say we may see a homeless person in the street talking to themselves. A parent may refer with the kids there that this is a crazy person. So it kind of rubs off on the children. That just makes matters worse. Yeah, I hope I answered that question.
Thank you, Charlene. Then there's a question: as a person with lived experience, what is your view around disclosure in the workplace?
Yes, that can be tricky. What I normally advise people is there's no law that, okay, in South Africa now, there's no law that forces you to disclose your mental health condition when you apply for a job. But then you must also remember at the same time that when you do not disclose and you get the job, for example, you are not entitled. You're not going to be entitled to reasonable accommodations. But what you can do, you don't need to disclose immediately. Once you feel comfortable, you learn to know your colleagues. And at that time, you've also proved your abilities and that you are able to do the job. So that also changes the perceptions of your colleagues and your managers or supervisors. So once you feel comfortable with a supervisor or a manager, then you can disclose. I usually recommend kind of that route.
Then will the recommendations be accommodative of poor countries that are already having substandard medical care facilities?
Yes, that is a big one. I think we need a lot of international support, because if you look at medical facilities, and I myself have been in government hospitals, I've been involuntary admitted. So it's really like, I usually tell people, it's like a prison. It's like devaluing me as a person. And that is also very stigmatizing, because the outside world, it's almost like you are locked up in that facility to keep you away from society. And we talk about inclusion, so you cannot have that. So I think we really need to try to move away from institutional care and really invest more in community-based care. And I think that's going to make a huge impact on countries, and especially low and middle income countries, because if you look at budgets in mental health, the largest parts of budgets go towards institutional care or specialized psychiatric hospitals. While, okay, it's going to probably cost a bit more to develop the community-based care, but in the long run, it's going to save a lot of money. And I think from international support, we definitely need that.
Thank you. Then here are two questions. I'm going to form them into one. So how can we assist someone with self-stigma, and how can we address self-stigma on medication for children?
Okay. I think the best way to address kind of self-stigma in a person is, I've seen a lot, what's a lot effective is peer support, for example, is one way. When there's other people who this person can engage with, I think especially in terms of role models. I mean, if I look in the peer network, a lot of our members, all with a mental health condition. Myself, running an international organization, that helps someone with self-stigma to see that they can achieve despite their mental health diagnosis. And I think we also need to always emphasize that. I know in the past, way back when I was diagnosed, I was literally told that I would not achieve at anything. I'll never be able to work again. I did lose my job at the time, but I was told that I will never work again. So I think in terms of medical professionals should really give hope to the person. And that is why I speak a lot about the recovery approach, because the recovery approach helps that individual. It gives them the hope that they can achieve what they want to achieve. Okay, you spoke about the second part of the question about, medication and in children. Yeah, I suppose there's a lot of debates. I don't have specific evidence or whatever is there. I know even we call it pole shaming. That's also kind of, for me, a form of stigma. I don't know. It's difficult. I think when we speak about someone with a child who has a flu, that child takes medication for that flu. So for a mental health condition, that child needs that. I don't really know how to, but I think people need to be educated. I think education is such an important aspect of it.
No, definitely. Thank you. Then we have, commonly people suffering from mental health conditions are barred from entering contracts or giving consent. Although in mild and moderate cases, some people are functional, occupationally, socially, and interpersonally functional. Do you recommend or have something in place to impact on laws like the National Credit Act be specific, especially with organic mental problems associated with decreased function?
Yeah, that can be a very complicated discussion. We speak a lot about the legal capacity issue, whether it's entering into contracts or whatever. There's the UN Convention on the Rights of Persons with Disabilities. That convention specifically causes quite a lot of debate around the legal capacity issue. But what's advised, I know South Africa, we don't have it. I think the new mental health law in India started with that, for example, where a person has an advance directive. So if at whatever stage a person kind of has diminished capacity, that they can appoint a person to support their decision. I think we absolutely need to avoid the substitute decision making, where someone else makes decisions on behalf of a person, no matter how diminished their capacities. We need supported decision making, because there's often the thing about substitute decision making is based on this person making a decision for me based on what they perceive is in my best interest, which may not necessarily be the case. Like I said, it's a very complicated situation, but I think we really need a supported decision-making act, whether you have a mental health condition or whatever condition you have, just to have that law in place for someone who has diminished capacity.
Thank you. Then we have, what role can school social workers play in destigmatization on mental health?
I think also to work with families. I think a social worker, like I said, there's quite a gap in terms of families, supporting families or educating families around mental health conditions. I think social workers can play a specific role in terms of working with families, but also kind of give hope to the children, the children in that family. And I would also say that social workers should also involve people with lived experience, to kind of be part of that team to engage with the family.
Okay. I think we have time for 2 more questions. We have a question here. Sorry, I just lost my space. How can we break stigma across cultures, specifically in Africa?
Yes, I think we all need to work together. I think we need to respect each other's cultures, and also understand where people are coming from. I think we need to understand that my experience with schizophrenia, for me, it's different than another person with schizophrenia, based on their culture and their background. I think we need to understand that and respect that. And I think we shouldn't be afraid to really talk about the differences we have in terms of our culture and our experiences. I think in the peer network, it's so wonderful having so many lived experience from different cultures. We learn so much from each other. And that is really amazing. And I think it will help break down stigma.
Definitely. We have, how is stigmatization affecting parenting ability or skills in people with mental health conditions? Are they still able to parent effectively?
Well, I suppose I wouldn't say a person cannot parent effectively. But of course, maybe I should use examples. I know people with lived experience who do have children. They educated their children on their mental health condition. And it's actually amazing to see how the children understand if the person maybe relapses slightly, how the person understands that behavior as well. I think having that relationship for me is amazing parenting. So I wouldn't. Of course, if the person goes to hospital or need to go to hospital, I still wouldn't say it's not a matter of not being able to parent.
What impact does sorry, go on, Shalene.
Sorry, I just wanted to say, except when abuse happens.
Yes, definitely, I do agree. What impact does non-adherence to treatment have in increasing stigma?
Yeah, non-adherence. What impact that has. I suppose that depends. That really depends. It's because, for example, I know people who live with schizophrenia and who do not want to take medication. They actually have a right to not take medication. Personally, my view is it's fine if you don't want to take medication, as long as your behavior as a result of non-compliance does not violate people around you, their human rights. Then I have a problem, because then for me, then it adds to the stigma of people being violent, people being, unable, unpredictable, and all those negative connotations. So for me, I always say that you need to take responsibility for your own mental health. You know yourself, you need to learn yourself. You need to take responsibility and take medication if that is what keeps you well.
Definitely. Then our last question, how to deal with a patient who has a mental health condition but is ignored by family and has no mental institution available for them?
Happening is very sad. When there's no mental institution, the families, I suppose one could always try to speak with the families. But one thing I would recommend that could probably work best is to involve another person with a mental health condition to speak with the family. I've done it quite a lot of times. People have referred families to me many, many times, and I have spoken to them. I think sometimes families do get frustrated, for example, with non-compliance. The person doesn't take their medication and they do funny stuff, and they just get fed up after a while. So it's not only working with the families themselves, but also another person with lived experience, a peer, could also help in speaking with that person and try to unite the family and that person, because I think family structures is so important.